Welcome to Ask the Expert with noted radio host Steve Sleeper. Each week, Steve interviews entrepreneurs and professionals and shares their intriguing stories of success and service. Now, here's radio veteran Steve Sleeper.
Our guest today on Ask the Expert is Dr. Gregg DeNicola, a family physician with offices throughout Orange County, California. I spoke with Dr. DeNicola about COVID-19 in general and the testing he's doing and his thoughts on the coronavirus in particular. I started by asking him to introduce himself.
Well, I'm Dr. Gregg DeNicola, the Chief Medical Officer and Chairman of Caduceus Medical Group, which is a multi-specialty group based in Orange County, California. We also have a division called PDQ Urgent Care and More that takes care of the more urgent and non-appointment type of situations. And that's what's been in the forefront of the COVID battle out here.
So how are you seeing patients now? Talk about that, because I know it starts with a video visit, and then if you need to see him curbside, you see him that way. Am I understanding that correctly?
Yeah, I'll try to make it a little more straightforward. We were the first, it was actually mid-February, we made the decision to not see anybody in the office who had a fever, who had the flu. So we actually would require video visits for the flu, influenza, which at that time we had a fair amount of influenza B. That was before we could even test for COVID. So although we knew COVID was coming, we didn't know really when it was coming. And then it was very popular to do flu swabs back then. So we would only do flu swabs and the doctor evaluation in the parking lot. Then when we were the first also to do testing, so we started doing testing for COVID and got our positive cases, and we then made a decision that any infection of any kind, flu, COVID, anything, would only be done via telemedicine or a video visit. So all of our COVID cases are taken care of through video visits. Rarely we have to bring them in for a breathing treatment or an x-ray. In that case, we put a hazmat suit on us and on them, and we escort them to the room they need to be in, but they don't stop and sit or talk, do what we have to do, disinfect the room, escort them back to the car. So there's really very little chance of coming in contact with anybody. Now, we're also doing video visits on routine things because so many patients did not want to come into the office just out of fear and paranoia. So for most of March and April, 80% of our visits were video or telemedicine, no matter what, whether they were COVID or just normal everyday visits. Now it's getting to closer to 50-50.
To start the video visit, I think all a person really needs to do is go on to either Caduceus's or PDQ's website, start a chat session, and you'll walk them through it. You know, the front desk person will walk them through it. Right. Do I understand that correctly?
Right. We actually have had more engagement on our apps. We have an app for Caduceus and an app for PDQ. And because everybody has their phones with them at all times, they can just pick up their phone or device and press the app. And then the website too, either way works. And then when they get onto the site, it's very easy. Just press a button to set up your video visit. Just in case there's any concern or questions, we have a live chat feature and it's staffed, when its office is open, so it's staffed about 12 hours a day. And then they can push live chat and they'll get an actual person able to talk to them, talk them through the process.
A little more about the curbside testing. How many hours a day is that? How many people do you think you're seeing?
Yeah, we change it every few weeks depending on demand. When we started off, demand was very heavy. Then it kind of trickled off, and just in the last 2 weeks, it's been very heavy because we got the antibody tests in, and those are very popular now. So basically, we have 3 locations, North, Central, and South Orange County. And in 2 of the 3, we just have a line of cars. You make your appointment for the video visit. You have the video visit, then they direct you to one of the sites closest to where you live, and you just get in your car and get in line and get it done. We do not do them in the office because we don't want patients to worry about who is in the rooms and who coughed in the office and all that. Currently, we're doing about 100 to 120 a day. At our slowest, we maybe are doing 40 or 50 a day, and our busiest, maybe 150 a day. So the last month, we've done over 1,000. We do a lot of testing, both antibodies and nasal swabs. The nasal swabs tell you if you currently have the virus active, and then the antibody tells us if you've had it in the past and formed immunity to it.
How reliable are the two tests?
There seems to be very little controversy on the swab. When somebody says, I think I have it, I have a fever and I'm coughing, if I do a swab, I feel very confident it's going to be accurate. It comes back positive. It's a very sensitive swab. It uses a technique called PCR, which is respected in the industry, accepted by all experts, so that's fine. The antibodies have had a lot of negative press because people are saying, well, they're not very accurate. They had to rush them to the market and they didn't get FDA approval. So the antibodies don't bother. It's a bad test. It's a bad test to tell you if you have it. It's not a bad test to tell you if you had it, maybe in Christmas time, or if you're immune now. The trouble is we don't know for sure antibodies will mean you're immune. We won't know that till the fall, probably. But right now our antibody tests are coming back just as we expect. If you had COVID in March and April, the antibody tests are all coming back positive. And if you didn't have COVID, it's coming back negative, which is what we would expect. So I'm probably the minority, but I think the tests have been fairly accurate.
How many positive results have you gotten for the COVID test? And what about the antibody test? Do you have the numbers on that?
Mm-hmm. So we've done maybe 1,500 or so swabs, and we've diagnosed about 88 active cases from those swabs. So without doing the math in my head, for the first month, it was averaging about a 7 to 8% positive rate on the swabs. On the antibody test, it's much less. We are running about a 3 to 4% positive rate. So for every 104 people test positive. So that kind of, as we predicted here, did away with the fantasy that we'd have 80% of the population walking around immune and they can go back to their jobs and go to the museums and resume life. Turns out the only way you really got immune is if you had it. And I mean had it enough to have symptoms. Very few people test positive who didn't know they already had it.
You talked a little bit before about how you're treating those who test positive, and that's pretty much done on a video visit, and you bring them in only if it's absolutely necessary. Did I understand that correctly?
That's right, but we still have had excellent results. Positive cases, we grade them as mild, moderate, or severe, and it's about 50-50. About 50 are mild or no symptoms, and 50% are moderate to severe symptoms. So no matter what, though, we immediately start them on a Z-Pak and zinc. Now, a Z-Pak will help if they have another type of virus. It will help anecdotally some cases of COVID, but I'm the first to admit there's very little data, but enough people felt better with it. We wanted to jump on it quickly. And then zinc was very theoretical. It helps the common cold virus. The coronavirus is one of the common cold viruses. So by simple deduction, it was like, well, let's try it for corona, and it helped a few people. So we continued we call it the double Zs. Then we have something called a COVID cocktail. We named it that. Basically, it's a Sudafed, which is over-the-counter, promethazine, which is a prescription cough medication, but it breaks up mucus, and an albuterol inhaler, which is prescription, and that opens up the lungs. And we start that immediately, even if they don't have many chest symptoms, because I've kind of called this the lung eater. Once it gets into your lungs, it's hell. It is just a nightmare. Normal, healthy people can barely breathe. So we want to keep those lungs as wide open as we can right from the very beginning, so fluid doesn't settle in there. So that cocktail has really helped a lot. Then as soon as they get enough of a cough or congestion, we begin what we call pulmonary hygiene is the 21st century term. When I was Creighton in the 70s, and we called it pulmonary toilet. Basically, it's 3 exercises where you turn, cough, and deep breathe. You blow up the little machine with little balls as high as you can go, and you have a partner percuss or cup their hands and hit their chest to loosen all the mucus up. That works dramatically, and we have been doing it 3, 4, 5 times a day. And it really empties the lungs of this mucus that's there. So that's how we're treating it. It's been successful. When the symptoms are significant enough, we add Plaquenil. I know that's very controversial, the malaria medication. We've used it 16 times, and all 16 improved almost immediately. So we, unlike some reports out of the East Coast or CDC that questioned its efficacy, we found it very effective. For some of the fancier drugs you read about, those are usually done in the hospital. We haven't used those. We've had 2 of our 88 patients have to go into the hospital. Both were very ill. Both got better, both on Plaquenil. And we've had no deaths, thank the Lord.
You mentioned a couple of things about COVID-19. It's a lung eater. It's like the cold virus. What else can you tell us about what it is?
Yeah, the reason I always kind of laugh when I look on social media and somebody's always comparing it to the flu, like the number of people who get the flu and how many people die of the flu. And I just think to myself, they just don't know. They don't get it, because unless you've treated COVID, you just don't get it. It's nothing like the flu at all. This virus is playing by its own rules. It mutated from the corona family, but the corona family has a lot of different strains. I guess a weak metaphor would be, you know what a dog is, but there's collies and German shepherds and poodles. I mean, there's a lot of different kinds of dogs, right? So you might think you know dogs, but you get a pet and you say, oh, I know dogs. I've had dogs my whole life. But this one's like a coyote or a pit bull. It has its own rules it plays by. It doesn't play by the other coronavirus rules. So, for example, this one is causing a large number of blood clots. Now, of our 88 patients, only 2 have had a blood clot, but the numbers are higher back east and in Europe. No other coronavirus does that. I mean, they can cause blood clots in your legs. They can break off and go to your lungs and cause death. We're seeing it cause liver failure, kidney failure, heart failure. No other coronavirus does that. So this virus is doing what it wants to do its way, and it doesn't care what other coronaviruses do. And it doesn't care what the flu usually does, because the flu doesn't do any of those things. These people, the moderate to severe cases, Steve, get really sick, and you can see it on the TV screen. It's actually haunting. They're begging. They say they can't get enough air. These are young, healthy people, 40, 50 years old. These aren't necessarily seniors in nursing homes. They're people like you and me, or younger than us, full-time jobs, play golf, tennis, and they say, I can't get any air. I'm taking deep breaths. Am I going to die? They have this look in their eyes like, help me, I need more air. Somehow get me air. It's very scary when you're watching it. And again, I never see that with the flu. I never see that with the normal coronavirus. So this virus is definitely really, really mean and acting by its own set of rules.
What can we do to protect ourselves? CDC's put out a lot of things that we know about, but I'd like to hear it from you.
Well, there are 2 things also different when people compare it to the flu. I always kind of say, well, there's 2 big different things. Then I'll answer your question, because they tie up together. The first is, we forget it's up to a 14-day incubation period. That's almost unheard of for most viruses and flus. Usually 2-3 days max. And it's not exactly 14 days where you can mark it on a calendar. It's up to 14 days. So if you told me this morning somebody near you had COVID and you're worried if you're going to get it, it's not like I count 14 days and then see. You have to worry every day for 14 days that you might get it. Number 2, it's very easy to catch. most colds and flus, they have to cough pretty hard. The droplets have to be pretty out there. You don't normally get it just sitting by somebody. But COVID, we call it penetrance. Penetrance means for every 100 people who come in contact, how many get it? And with the common cold or flu, it might be 10% penetrance. But with COVID, it's 50 to 75%. It's so easy to get it, which is another reason this is such a bad situation we're in right now. So to answer your question, all the common sense things make sense. The social distancing, washing your hands. I don't understand the controversy of the masks. I know a lot of people are saying, well, the masks aren't helpful. Of course they're helpful. Why do you think surgeons wear them in the OR every day when they're doing surgeries? Because they work. Because the surgeon doesn't want to cough or sneeze on the patient, and they don't want the patient's bacteria to get into them. So masks do work. There's no question they work. True, for coronavirus, you need a special mask, but it's not like other masks don't work at all. They just don't work as well. Because common sense says if you're going to sneeze or cough, you cover your face with your hand. That's just politeness. So all the mask is doing that all day long as you walk around. So again, I don't see any reason to have any controversy there. Masks do work. Now, whether you need to wear them when you're driving by yourself, of course not, or taking a walk with your dog, no, of course not. But when you're coming near people, yes, you should have a mask on. It's interesting with the social distancing because really the last 2 months, the only infections I've seen has been COVID. Like that's been the only infection I've seen. There's been no common colds. There's been no flus. There's nothing spreading at all because nobody's near anybody. Everybody's in their house.
Everybody I've asked, when do you think it's going to end? They've basically said when it ends.
This is tough because, again, this is playing by its own rules. The flu peters out on its own every March, like without fail. And it comes back with a mutation every October without fail. It's almost like the swallows in Capistrano. We know for sure it's going to come and go during those seasons. And we know even the rest of the coronaviruses, which cause common colds, they start in the fall and they end in the spring every year. We know that. So this one, though, we don't know. We have no idea. When they asked me that a few months ago, I said, I think you're going to see the numbers dramatically fall in mid-May. Well, we're in mid-May, and if the numbers have fallen at all, it's because of the social distancing and masks. It's not on its own. It's gone away. So then I said a few weeks ago, I think it'll be mid-June. So I still got a couple weeks to see if I'm right there. Not that it'll go away completely, just that we'll see the numbers start to drop dramatically and we can relax a little more. But now the experts are all saying it could go, a year or two. I don't know. I find that very hard to believe. So I think it's just a month by month. Take it a month and see, and take it another month and see.
Many thanks to Dr. Gregg DeNicola with Caduceus Medical Group and PDQ Urgent Care and more for being our guest today.
Thanks for listening to Ask the Expert with Steve Sleeper. Join us next time as entrepreneurs and professionals share their intriguing stories of success and service.